but it's a good illustration. It shows how you can start out normal, you start to see some changes, and if they aren't corrected quickly, the body compensates in all the ways that it can before it no longer can at all. Any questions? Great. Okay, now we're going to position hypertension. Huh? I would have figured it out.
Alright, so I know a lot of you, or most of you, have come to the eclampsia hypertension sim. So this should just be a very quick review. Again, hypertension is anything over 140 over 90. And then how do we normalize this? We say she feels fine, it's chronic, this is her normal, she's just in pain, she had to fight with her family, there's so many people in her room. And then all her labs are normal, so it's probably fine, right? I mean, the doctor didn't seem to care. So again, these are just kind of showing you more of like a picture of, again, it's either going to be related to flow or it's going to be related to resistance. And then a combination, which would be option C, that would just be more of like along the lines of heart failure. So, again, we're going to talk about medications, right? So we know we have a high blood pressure. There's not a lot we can do to fix it rather than give her medication. So if we look at the two reasons for high blood pressure, right, there's a cardiac output or flow, and then there's resistance, which is the systemic vascular resistance over here. So labetalol just works on cardiac output, right? So it's just going to work on this flow. It's a beta blocker that works on flow. And then if we're looking over here at resistance, hydralazine or nifedipine procardia are just going to work on the resistance side of blood pressure. So hopefully this kind of gives you a visual depiction of why we use one drug and why we need to switch to the other one if it's not working. So let's go through the labetalol protocol. So our first dose is 20 milligrams. 20 milligrams, and we're going to push that over 2 minutes. And then how long do we have to give that to work before we move on? 10 minutes, right? So 10 minutes is how long? Does that mean we need to hit her blood pressure every hour or every minute, and then every 2 minutes, and every 3 minutes? Like if she doesn't have enough petechiae, then we're not doing it enough, right? That's how I roll. So you give 20 milligrams over 2 minutes, we're going to wait 10 minutes. If our blood pressure is still in severe range, what are we going to give next? 40, and then how long do we have for that to work? 10 minutes, right? So we're not waiting longer. It used to be 30 minutes. We're not waiting that long any longer. Because what this is this is a stroke range, right? We're always concerned about preeclampsia and eclampsia, but what we're more concerned is as we see moms dying, we're seeing they're dying of stroke, and this is why. So our third dose is going to be 80, right? And then we're going to give this 10 minutes. So we are no longer going 20, 40, 40, 80. We're giving 20, we're giving 40, we're giving 80 in a 30-minute time period. And if that's not effective, do we think it's a flow issue? No. So what is the problem? It's a resistance issue, so we have to switch drugs. We're not going to know what our patient's blood pressures are related to unless we have a bedside echo, which we're not going to have. The best way and the quickest way and the most effective way that we can intervene for our patients is if we've given them the drugs that are not working, we have to switch to the other drug. Alright, so we're going to recheck in 20 minutes, then what's our next dose? Hydralazine. So we're switching to hydralazine now because most likely this is going to be a resistance issue, and we're not starting with 5, we're going to go straight to 10. Okay? If it's still high, she probably needs some kind of cardizine drip or something like that, and another land that doesn't belong to us is where she needs to go at that point.
But they won't take her.
So.
That's for another conversation. So now we're going to talk about hydralazine. Yes?
Can we get these on a badge, buddy?
They're in every room laminated.
Can we get them on a badge, buddy?
We did. We made those, but hold on.
Yes.
Okay.
Yes.
I think postpartum
We gave them to
got
postpartum
them,
actually.
and some of us got them. Hold on, let me make
Yes.
It's a lot of numbers.
It's a lot of numbers and it's a lot of things. But this whole algorithm so the hydralazine, labetalol, and nifedipine are all on one little algorithm, and it's laminated in a sheet of paper, but I'm sure we can do
We
something
should do a
for
bag
just
study. I would be
to
good.
these.
This one
Yes.
isn't quite as detailed as this, so that might be
Yeah.
I
better.
haven't seen them on
Hmm?
I haven't seen them on.
I have one.
Yeah,
I was supposed to say
we
so,
did an
yeah.
in-service, but it doesn't have like this. That was before this algorithm, I think we had it. Maybe.
Is that linked to the preferences?
Not yet. So in Epic right now, since they're building Epic, this will all be built into Epic, but apparently we were told that we can no longer do anything in EHR and that everything is being worked on. So right now, if you were in labor and delivery, or I guess a doctor could put them in for you guys, you would still select the hypertensive, but you would just select the 20, 40, and the 80, and then you'd have to then change the preferences to every 10 minutes, which takes a while, or you have to handwrite it and fax it to pharmacy until Epic comes. So that's kind of our workaround for right now.
This is why it's so important that y'all are here knowing this,
It's true. It's true.
because we can't.
So we'll go to hydralazine now. So some doctors prefer, I would say like, 75% prefer labetalol. There's only a couple that will start with hydralazine. The first dose that's recommended, Dr. Blake reviewed this with all the physicians, and they'd like us to start with just 5. So we'd start with 5 milligrams. How long are we going to wait for hydralazine? 20 minutes, right? So it's different. So if you're using labetalol, then it's 10 minutes, but if you're using something that works on resistance, a good way to remember this is if you're working on resistance, you wait 20 for both nifedipine and hydralazine. So we're going to wait 20 minutes. If our blood pressure is still high, what are we going to get next? 10. So we've gone 5, we've gone 10. We're going to wait how much longer to reassess? 20 minutes. If we're still high, then we're switching automatically. Okay? So we've given this about 40 minutes, 2 different doses to be effective to bring our blood pressure down below seizure and stroke threshold. So then we're going to automatically switch to something else. So if the blood pressure is still high, is it related to resistance? Probably not. It's more likely related to flow. So now we're going to give 20. We're going to repeat it in 10 minutes, right? Because we switched drugs, we switched classes. So now we're going to not wait 20 minutes, we're going to wait 10. And then give 40. And then if that is not effective, again, she needs a higher level of care than we can provide her. Okay? So this is a newer protocol. We kind of talked about this in the hypertension spectrum class. Some doctors are using this, like I know Dr. Decker's used it, Dr. Kamak has used it, a couple other ones I can't remember have used it. Yes, Palmer has used it. And again, this is a drug that's just working on resistance, so we're going to wait 20 minutes, okay? Just kind of keep that in the back of your mind. So we're going to give 10 milligrams PO, okay? So this is a non-IV drug. PO, we're going to wait how long? 20 minutes, then we're going to give 20, we're going to wait another 20 minutes, and then we can give a third dose of an additional 20. So studies are finding that this actually works so much better in hypertensive crisis than the other 2 IV drugs because it brings them down a little bit slower, like kind of stair steps them, and then keeps them stable a lot longer. The only thing you would need to know if the patient's on MAG, like an antepartum or labor delivery, you might want to go to this because it is a calcium channel blocker as well. So then that would be something to kind of keep in the back of your mind. But again, if we are switching, so why would we want to switch labetalol and hydralazine from Procardia? It's the same drug, right? So we're working on resistance. If we give hydralazine, is it going to be effective? No, because if this hasn't been effective, then that's not going to either because it is the same classification of drugs.
Flashback to the other class. Does anyone, just because it helps you remember it, does anyone remember why you wouldn't maybe want to give Procardia with MAG, besides the fact that it's a calcium channel blocker? This might help you remember why, or remember it in the future. Remember, calcium's the antidote, so if you're blocking it, the MAG could potentially be, the MAG effect could be more. Like you might give, it would be like too much.
More toxic.
Yeah.
So we kind of add the slide after talking to several nurses from New Family Center. A lot of questions have come up through our classes that y'all are giving a lot of PO. So at what point do you need to give something IV? Like how long do we give a medication to work before we need to do IV? Or ask for either like Procardia or labetalol. Like if she's on labetalol and we've increased it so much and done like TID, then maybe asking for something else that's going to be a little bit more effective. But, so the onset of each medication is about 20 to 30 minutes. So about 30 minutes in, if you have not seen a change in her blood pressure, we think that at that point, talking to pharmacy, that it's safe to then call your doctor and get something IV. Does that make sense? Because when 20 to 30 minutes, it should have been effective. So each of those medications, again, depending on which one we're using, they should have started lowering of blood pressure. You should see a change within 30 minutes of giving that PO drug. And if you are not, then that's the point we need to call the doctor and advocate for something either additional, like increasing the dose, switching the different classifications of drug. Maybe she's on labetalol, we need to get her Procardia XL, or I've seen some doctors I've heard like give both. Okay, any questions with that? So here is our case study. This case was before we started the new algorithm, so we kind of walk through why we switched drugs again. Hopefully this kind of puts it in your brain a little bit better. 36-week drug from the office for BPD valve. At 1 o'clock they start her IV, they draw labs. Do we care about her blood pressure? right when she gets an initial and a repeat. Is she in stroke range? Is she at risk for having a seizure? Yes. We need to give her medications. So the first dose was given at 13:28. So again, we're not going to be super effective until right around in here. Are we still in stroke range? Absolutely. So we give 40. Okay. Are we still in stroke range? We had to give additional 40, and we give additional 80. So are we still in stroke range after giving 4 doses of antihypertensive? Yes. So what do we need? Hydralazine. Right. So it's not related to flow. It's a resistance issue. We need to give a different kind of drug. So the RN calls the MD. They get an order for hydralazine. They give it at 14:20. And are we still in stroke range? No. Right? One thing also to remember is that labetalol is a beta blocker, and it lowers your heart rate, so you know it's effective when it starts bringing your heart rate down. So you can see that it's working, right? It's doing its job, but it's not effective in bringing this patient's blood pressure down because she needs a different type of drug. Any questions with that one? Okay.
Never remember this is me.
So again, we're kind of wrapping up the class now. Our goal in teaching this is that if you see something abnormal, really assess the whole picture, because one abnormal vital sign really means nothing in the span of everything else. So you find something abnormal, you need to assess, and we need to think through what is the cause of her abnormal vital sign, and communicate that effectively with the physician. And we'll talk about that in a little bit. But giving a physician one abnormal vital sign without the whole picture doesn't get us aggressive treatment. If I call a doctor and say my blood pressure is this, this, and this, and I don't give him the full picture, he may or may not give me any medications. But if I say a patient has a blood pressure of this, she has a headache, she has clonus, she has this, and I go through my entire assessment, that's going to be a lot more meaningful and get us a lot more aggressive treatment for our patients. This is you.
So Courtney just kind of did this one, but one vital sign means nothing. You got to communicate the whole picture to the MD, and then you have to do a full assessment when you find that abnormal vital sign to kind of determine, is this really abnormal, is this normal, especially blood pressure, heart rate, some of those things that just may be they're normal, but what is their urinary status? Are they symptomatic? What are the rest of the vital signs? How do they feel? Are they tolerating it? Are they compensating? All things to think about. Okay, so our first case study. This patient came into the OB-ED. She ended up having an SAB and bled 300. When the RN was preparing for discharge home, she noticed that all of the blood pressures were like 90s over 50s. A few of them were lower than that, and that's a little bit low. So, okay, was that normal or abnormal? It's abnormal, a little bit. Okay, so what else do we need to know though when discharging her home or when calling the doctor?
Heart rate.
Urine output, how does she feel, all of those things. I didn't do a good job presenting this one. Anyways, so yeah, the nurse for this patient was me, and I called the doctor and I told her, okay, her blood pressures are this is what they've been the whole time, and she's like, okay, what else? I didn't just go off and say her heart rate this is this, she's peeing, she's eating, she feels fine. So I did not paint a good clinical picture for this doctor when she's trying to make a decision, and she called me out on it. She's like, okay, what else? So it illustrates you need to include everything else. One vital sign means nothing, because in this case the patient was normal. I don't know what her normal blood pressures were because she was so early and just came in, but she was like this the whole time. And she felt fine, and all of the other things were normal. So this probably just was her normal blood pressure. You can be normally abnormal. Okay.
So a patient arrives for induction. This is her blood pressure, normal or abnormal? Abnormal. What else do we need to know?
Is she symptomatic?
Is she having headaches? She has dizziness? Is she 10 centimeters? Would that make this normal, right? I mean, did she just have general anesthesia and she came back from surgery and we're rubbing her fungus, right? So again, painting the picture that, again, one abnormal vital signs mean nothing. We have to take it in the context of the clinical situation.
Okay, this one, the patient is admitted from triage to labor. Her heart rate is 118. Is this normal or abnormal?
Is she hurting?
There's so many things. This can be any situation, yes. What else is going on? Is she pushing? Or she's just sitting there chilling with a fever of 101. Like, all of those things are important. You can't just call and be like, hey, her temperature's 101. They're gonna think you're dumb, like, okay.
C-section recovery on MAG, pulse ox is 94. Normal or abnormal? What else do we need to know, right? What is her urinary status? What is her MAG level? Turn the MAG off if you see this. Does she have oxygen on? Did she just have a general? Is she aspirated? Does she have pulmonary embolism, right? All the things. What else? You're about to say something. Okay.
Yeah, all of the things. You cannot do one vital sign. You have to look at the whole picture and paint that picture for the physician. Which, okay, now we're going to talk about charting it. So, when you see something that's abnormal, you need to chart that you recognize it. So, example, blood pressure noted. Note what you do. So, like most of our first thing we're going to do is adjust the cuff. Okay, so noted, blood pressure, cuff adjusted. Then you need to chart your related assessment. In this case, again, it would be a clonus, headache, DTRs, all of that, urinary status. Document it, and then communicate to the physician. Note or write that you communicated to the physician, and then you need to chart what they told you to do. The big thing on this one that I wanted to say is if they don't give you an order, you should not chart no new orders received. We learned that in a legal conference. They said that if you chart no new orders received, it implies that you were that you intended to receive orders that you did not. So it opens up a big legal playing field for the lawyers. So if you did not receive orders, you should just say we'll communicate or we'll continue with current plan of care. And if you did intend to receive orders that you think you should have received, you should go up the chain of command. Don't just stop there. Talk to your charge nurse. Okay, so the takeaway is vital signs are clearly vital. They mean a lot. But one without the rest means nothing. Do not normalize an abnormal without further assessing. It may be normal, but you can't be sure without doing your full assessment. Communicate all findings and assessments to the doctor and chart that you did so. And then one of the big takeaways from this is because cardiovascular disease in pregnancy is the #1 killer of our pregnant women, we have got to be better. Blood pressure is the biggest thing. If we are not giving a medication that is effective, we have got to advocate to change the blood pressure. We've got to advocate for a change in level of care. We are the ones at the bedside. We're the ones seeing this. We're the ones that are going to save these women's lives. So be your patient's advocate. Any questions? Okay, if you want to stay for a Spinning Babies demonstration,